Dr. Dillon will speak on what is new on the horizon. Joe?
All right. So I'm very excited to give this talk. This is because it's exciting to see what's new. It's exciting to see how far we've come. I realize that any of you out there who have a neuroendocrine tumor or who have a loved one with a neuroendocrine tumor, research never goes fast enough. Results never come quickly enough. New things never come quickly enough. And I take your point, but I want to show you some of where we've come from and some of the exciting things that we're looking at doing soon. So, what's on the horizon for diagnosing and treating NET patients? So, to start this, I want to go back a little bit. This comes from I'm talking a lot from the papers of the folks at MD Anderson. They have a really great group there, and they publish a lot of important studies. They published a study in 2017 which looked at the trends in neuroendocrine tumors, basically from 2000 to 2012. And this graph shows the trends in survival of patients who had metastatic pancreatic neuroendocrine tumor between 2000 and 2012. What you see on the vertical is survival, with the survival at year 2000 being the 1.0. Survival improves 24% by 2005 to 2008. It improves 44% by 2009 to 2012. So survival improves, and survival improves because of new therapies. Now, Dr. Odorizio and I, when we see patients in our clinic, we go over this rather complex table with them, which shows all of our approaches to treatment and diagnosis. But I'm going to hone in on a couple of aspects of this slide, and I'm going to hone in on the aspects of diagnostic scanning and the treatments to focus on what's happened just in the last 10 years. So looking at this slide, I've just put in here in yellow what are the dates of initiation of new things over the last 10 years. So gallium DOTA-Tate scanning came in 2016, DOTA-Tox scanning 2019, lanreotide 2014, telotrestat or Zermelo 2017, Afinitor 2011 for pancreatic neuroendocrine tumor, 2016 for carcinoid tumor, 2011 for Sutent as well. 2011 was an amazing paper showing the effectiveness of CAP-10, which had been around for a while, but that was the initiation of CAP-10 in neuroendocrine tumors. And then 2018, Lutathera, PRRT. So these things are in the last 10 years. They weren't captured on that previous slide, but they will be captured on the next time that those folks from Houston do that study, and they will translate into further improvements in effectiveness. But what I now want to talk to you is going forward from 2020, what's new? So what's new with gallium scanning? And Dr. Mayer has already alluded to this. Gallium PET scans, they produce great images. They produce such a better image than Artria scans, which were great in 1994 when they came in. This is the same patient, these two scans. On the left, you have an Artria scan. You see that just behind the collarbone on the left side, there's a black blob. On the right, you see the same patient a few days later with a gallium DOTA-Tate PET scan. I'm going to talk about what's new in PRRT, and there's lots new in PRRT. And Dr. Mayer gave a really good talk about Lutathera PRRT. So now that we have PRRT, how do we make a better PRRT? Well, we can try and get more radioactivity on the tumor for longer. We can try and make it more lethal. We can try and give it to where it needs to go to. We can do, and there are studies looking at multiple other aspects of combinations and other studies on PRRT. But I'm going to go on to this slide here because I want to point out two things. Dr. Mayer has told you that on tumor cells there are somatostatin receptors. There are active somatostatin receptors, and those somatostatin receptors will be the Lutathera attached to those. But actually, there are many more somatostatin receptors on a cell, many of them being inactive. It's like the bus service when you see on the front of a bus that it's out of service. There are many more buses than are active in service in the city at any time. So Ipsen have come up with a compound that will actually attach to both the active receptors and the inactive receptors. It's called Satoreotide. It used to be called JR11. Interesting molecule. And what I want to show you here is that this is a patient who was given Satoreotide on the top pictures and given the same small dose of Lutathera, not a therapeutic dose, just a tracer dose. And what you see on top is that look at the black tumors in the pelvis. They are much blacker in Satoreotide than in the Lutathera. There is much more radiation on these tumors. Additionally, if you look at what happens 72 hours later, there's still lots of radiation on the Satoreotide dose, but there's very little radiation. There's less radiation. So this new compound will give more radiation onto the tumors for longer. Dr. Mayer alluded to alpha particles. So lutetium is a beta particle, and alpha particles are very large and very damaging to tumors, whereas beta particles are smaller and less damaging to tumors. And I think just to give you a taste of the promise of alpha particle PRRT, because this is the first description of a study in the United States with alpha particle PRRT coming from Excel Diagnostics in Houston, where they found that 73% to 33% decrease in tumor size with alpha particle PRRT. That is huge. When they did gallium dotatate PET scans on patients, 2/3 of them, or 2 of 3 patients, so small study, 2 of 3 patients had full response. I don't have any pictures to show you from that because it's not published yet, but we do have pictures to show you what alpha particle PRRT does in other cancers. So in prostate cancer, they use a compound called PSMA. It sticks to tumors just like dotatate sticks to tumors. And so this is a man with prostate cancer. On the left, you see all prostate cancer on the PET scan. He received 2 doses of lutetium, PSMA, and it just got worse. Then he received 2 doses of alpha particle PRRT, and the 2 pictures on the right of your screen show that essentially all of the tumors are gone with that. So this is a huge promise.
One party in the conference.
We will see it in the next few years. Liver embolization, I'm just going to focus on one thing in liver embolization, which is that we can now use liver embolization, or the same protocol as liver embolization, to actually get PRRT right to liver tumors. This here is a picture of what happens when we give gallium either intravenously, the usual way, or give it directly into the liver. So on the top picture, you'll see in the little red arrows that the two tumors in the liver, much darker, getting much more radiation with the artery injection. So that is another great area of research. This shows one particular patient on the left, pre-therapy, and then after multiple cycles, you can see that all the tumors have gone away. This is still an area for research. So the folks in San Francisco found that it didn't work well recently. So there are ongoing studies in New York, San Francisco, Iowa. We'll see how that turns out. Finally, what's new with medications? There are lots of of studies of drug trials in neuroendocrine tumor. This was just a list of them that I found from going through clinicaltrials.gov. And I don't want you to look at the specifics of them. There are new medications, there are combinations of medications, there are old medications, but just to get a sense that there are lots of them. So when you need a different treatment, ask your doctor if there are available clinical trials that you would benefit from. And finally, I'm just going to cover one aspect of a couple of medications which may come out within the next year, or maybe FDA evaluated. Currently, we have Sutent and Afinitor, and what they do is they inhibit progression of tumors for 11 months. There are trials which have been completed and ongoing with a thing called surufatinib, pazopanib, cabozantinib, which increase progression-free survival by up to 3 times what we get with sunitinib and everolimus. Again, the full studies have to be completed, but very exciting. So once again, I'm sorry to run through this because of technical issues. Thank you for your attention, and we'll go back to Dr. Rodriguez.